Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. Today's special guest is Dr. Bianca Weinstock-Guttmen, professor in the Department of Neurology in the Jacobs School of Medicine and Biosciences at the University of Buffalo and a physician with MD Neurology. Weinstock-Guttmen is widely known as a leading expert on MS in adults and children, the executive director of the New York State Multiple Sclerosis Consortium, one of the nation's largest MS registries. She has pioneered new therapies and interventions to treat the disease while helping to develop a more nuanced understanding of the many ways MS affects patients. Her research includes studying the cholesterol link to the MS, bone health, and exercise programs for aging MS patients, and biomarkers that may help predict improved quality of life for patients. She also directs the Pediatric Multiple Sclerosis Center of Buffalo, one of the initial 6 centers of excellence established by the National Multiple Sclerosis Society. Welcome, Dr. Weinstock-Guttmen.
Thank you.
It's wonderful to have you here. How was your vacation in South Africa?
Was amazing. Recommending for everyone. Really, it was great.
Oh, I bet that was. I have always wanted to visit South Africa. I bet that was a fascinating
Worth to do
trip.
it. Put it on your bucket list.
Definitely on the bucket list. Now, with the approval of Ocrevus last year, it's an exciting time for those living with primary progressive multiple sclerosis. We're finally being included in treatment trials. Doctor, what are the other medications in trials for the treatment of PPS, and do any of them show real promise?
So there are newer medication now tried on primary progressive that's considering to do what we're calling a different mechanism of action than the rest that the ocrelizumab is part of it, meaning the anti-inflammatory. We're looking primarily in preventing neurodegeneration, meaning loss of tissue, and eventually repair. So there are 2 ongoing studies today. One is actually finished the phase 2 trial. It's called Ibudilast. It's an oral medication. It is also shown benefit on from Japan, benefit on asthma. And the study was, the results of the study were presented, part of it, at the ECTRIMS.
Yes.
They're ready to be sent to publication in New England Journal, and hopefully they will make it. It's considered to be a product that may protect the tissue. And it's included in secondary and primary progressive patients, so progressive patients. The primary outcome was based on the MRI, so preventing the brain atrophy, so the shrinking of the brain, and it did meet the primary outcome. The number of the patients, when we're doing studies, we're trying to determine how many patients can get in, and they to show a benefit. So this was based on MRI data and not on clinical data that may require more patients. So on the progression, what we're measuring with the scale we're calling EDSS did not show benefit. And another measure, we looked for the measures of the optic nerve. It's a so-called OCT, optical coherence tomography. We didn't see much benefit either. But the primary outcome, based on which the number of patients were included, it did reach benefit. So that is something that we'll probably look forward for a phase 3 trial, a larger sample of patients, and eventually looking for FDA approval. And the second one is the high-dose biotin. The high-dose biotin also will include secondary and primary progressive. It's an ongoing trial, multi-center, that biotin is a vitamin B7. but in a very high level as compared with what we have on the shelves. We do use biotin for hair and nails and, skin benefits. So over there you can find on the shelf on different measure. You find it in 1,000, 5,000, 10,000, but it is micrograms. The dosage used for the study is 100 milligrams 3 times a day, so 30 times more than maximum. So it's an ongoing trial. The phase 2 did show preliminary benefit and actually improving the disease, considering that may have an impact on remyelination and repair.
That would be wonderful. Yes.
So we're waiting for the results. There are many patients that are using it as obtaining it from compound pharmacies.
Yes. That's really popular.
Still have to be careful, though. There is certain consideration, even on the study, that included patients still on therapy, although there is still a question about the existing medication, if they had any effect on patients already progressing. But around 25% of these patients were on medication. But there was only the first line, the injectable, Copaxone and interferons. So the analysis was not, divided on whoever was on medication or not. But it's considered to eventually be as an add-on if considered. It's not only medication alone.
Yeah, it wasn't the primary treatment. That's very interesting. And the Butylast did not have the visual outcomes that, say, Ocrevus has shown. That's interesting as well.
Yes.
Yeah, that's very interesting. So we definitely need to read more on that, those of us who are primary progressive. Now, Dr. Weinstock-Guttmen, you have been involved in research to confirm the safety of DMTs during pregnancy. Is Copaxone still the only safe option?
Copaxone and interferon are both safe, meaning considering to become pregnant while being on medication. Unfortunately, we do not know when you're getting pregnant, right?
Right.
So it's very difficult to consider what are we doing in patients that want to become pregnant, discontinue the medication. Clearly, during the medication, it's better to have contraceptives and not to become pregnant. If it happens, the medication should be discontinued.
Yeah.
There is the primary concern on patients on Tysabri. Patients on Tysabri, if they discontinue the medication, become pregnant and discontinue the medication, there are risks for actually reactivation of the disease. Pregnancy is what we consider a protective time, but the protection is starting only from the last half. It's primarily even the third trimester. So the first 2 trimesters, there is no protection. So that's the problem that, the first 2 times, and when it's very important for the development of the baby, that you don't have much control on your disease, and then discontinuing the Tysabri, usually the 3 to 4 months after, may increase the risk for new relapses, and sometimes very severe. So there are certain patients that are coming more and more kind of case studies showing that patients on Tysabri may need to continue. This has to be a discussion really with the physician, and it's very much depending on what was the disease status before the pregnancy. Yes. Very important. Also, we try to consider patient to become pregnant as a planned, and to try to be on the stable status and not to be active.
Yes.
But clearly what the study showed that, mostly from retrospective but also prospective databases, the best is really in Germany, that patients that are well controlled and on medication before the pregnancy, they are better during and after the pregnancy. After the pregnancy, there is an increased risk for relapses, especially between the 3 to 6 months. And that is really the question, should or should not start the medication that usually prevent to breastfeed. On the breastfeeding is still a question, is this breastfeeding pure breastfeeding really protective or not.
Right.
And there's still, a question on this, and this has to be really discussed with the doctor, with the status before. Everyone wants to, the best of the baby and to do breastfeeding,
Exactly.
but it's very important to consider the health of the mother.
It really is. And that's one thing that we see in our women's forums is that one of the biggest questions is what's going to happen after, because they all talk about, well, I experienced my worst relapse after pregnancy or after the C-section. And they all worry, well, will that cause an even greater relapse than I've experienced before? Will I experience that after? And now I have a newborn to care for. And that's really one of the concerns they have when family planning.
It's right. The interesting fact, though, we're looking on what it was before, on the history. And it's not all the time the same, meaning we have patients that may have relapsed after the first pregnancy, second they may not have. So it's not 100% informative.
Right.
But in general, it's important how was the disease before the pregnancy. That is most informative on what will be next, although there's not a crystal ball.
Exactly. And I really say it's all about what support system too you have after the baby's birth. If you have a good enough support system, then that can also impact your decision.
That's very, very important. Very, very important for everyone, not only with patients with MS.
Exactly. We've all experienced that.
Absolutely.
Now, doctor, another thing that really concerns women living with MS is during that family planning is, will they pass on MS to their children? MS being a genetic disease and not hereditary is confusing to many patients. Can you kind of explain that to our listeners?
Sure. So when we talk about genetic diseases, meaning it's primarily you have a 25% risk or 50%, depending if it's the risk of the genes. But in MS, we have between 3 to 5% only risk. So there is a consideration genetically, but it's very low. The interference with what we call environmental factors are very, very important, as well as the gender. Clearly, we absolutely consider and recommend our patients to become pregnant. There is no more whatever was in the early 90s and so on, that was patients with MS were prevented to become pregnant.
Right, they were told that, yes.
Again, besides that, we have medication today, and we can, recommend what's necessary based on the patient status. But there are actually more studies coming up from different registries, including ours in USA Consortium, that actually found better outcome in patients that have children. The patient did not have children. All the time, you can have what we're calling a reverse causality and saying, okay, the patients that did have problems and so on, they are concerned, they don't want to have to become pregnant. And that's all the time we cannot really tease out. But, taking all together, it's clearly suggesting the patients that are pregnant. And there is a trend. We don't have yet too much, but as more pregnancy you have, you may do better further. So what is exactly the mechanism? It's not 100% known, but it's clearly suggested that not only during the pregnancy, but also having children may have a benefit.
So it could be actually the hormonal benefit, and then it could be the emotional and support benefit of having the larger family and that support system. All of it. Yeah.
All the above, yes. So it's clearly not preventing it, but, looking forward and planning it, and it could be only, feeling good and having a big family.
Yeah, so they'll have to consider timing, they'll have to consider support system, they'll have to consider disease activity, medications they're on, and just plan it all with your doctor as a care team.
Absolutely.
Very good advice. Now, as I stated earlier, you direct the Pediatric Multiple Sclerosis Center of Buffalo, one of the initial 6 centers of excellence established by the National Multiple Sclerosis Society. Where are we in the treatment of pediatric multiple sclerosis?
So up to now, we're treating children the same as adults.
Okay.
And the first time now, it was presented the data on the first randomized study on pediatrics that compared the Gilenya, the fingolimod, versus Avonex. The study was positive, providing, it's very interesting actually that on a previous study that compared Gilenya to Avonex in adults, MS, they showed an improvement of 50% on reducing the relapses. In children, it was the difference of 85%.
Wow.
So that is primarily related in children. They do have a higher risk of relapses. They almost may have up to 4 times more relapses, again, not treated. So younger people, including the majority of children, are really adolescents. So it's all probably related to hormones. And we know that younger patients in general, up to 30, 35, they will have a much more active disease versus older people.
Yes.
In the same time, though, they have a much higher possibility to repair and recover. And that is based on the resources of the brain and repair processes from the oligodendrocytes, the ones that are producing the myelin. So the repair processes in young people are much better than the older people. Anyway, both have to be treated and prevent any kind of damage.
Yes.
So the first time it was shown, they said that the 2 medications previously beneficial in adults, similarly and even comparative better in children. So it's safe, and they were waiting for the FDA approval specifically for the pediatric group. But at the moment, we do treat our children very similarly. We have a recent paper that will be hopefully published shortly on the experience of our large network on different medications, first line and second line of therapies. And sure enough, we do see an increasing for the last 5-6 years, in increasing on using the second line therapy as the first line, meaning the oral therapy before the injectable. Still, the injectable are the first mostly used, but the use of the oral medication started to go higher, even as the first line.
Wow. And it's there's people think that there's more prevalence of pediatric MS. I think it's more, and you can correct me if I'm wrong, it's just that it's being recognized. There's always been pediatric MS.
I absolutely agree. Meaning, the pediatric neurologists are trained now. There are more and more interest in pediatric neurologists to specialize in MS. And everything was before was considered what we're calling ADEM. ADEM is post-viral disease that is only one-time event and never reoccurring. Doesn't require treatment.
Right, and now it's being recognized. Now, is there anything we can do as parents to help lower our children's risk of developing MS?
Absolutely. So what we can do is working on the environmental factors, right?
Okay.
So from the environmental factors that we know that are related to risk for MS, first is low vitamin D, so limited sun exposure. It's actually interesting that it's suggesting that the sun exposure is maybe even more important than the vitamin D.
Right.
But, you have all these dermatologists that are,
telling you, no.
It's probably with melanoma and all these things. But
it's a risk-benefit kind of thing.
Give them a little bit, sunscreen and send them out.
Send them out anyway.
As much, sun you can get it out, and leave them from the video games and other stuff.
Exactly. Yeah, unfortunately, they're spending more time indoors on electronics now.
messaging,
yes.
and video games, and and actually, I would like to mention one of the other important things that was really, included as an additional factor for risk besides, vitamin D deficiency, smoking, and the second hand smoking. It's also involved, but clearly, please do not smoke. Please do not be friendly with friends that smoking. It's very, really risky.
It really is important.
The infection, the mono, we don't have any vaccination for EBV.
Right.
But what is important is actually to go out and be connected and so on. It's actually having the EBV as mononucleosis that is the highest risk is meaning exposure too late.
Too late in life.
Too much hygiene. Too much hygiene. Go on out and whatever. Don't eat
Live
dirt,
life.
but live life. Yeah.
Roll in the grass at least. Don't eat the dirt, but at least roll in the grass.
The fourth time that is actually very important is coming up. It was first shown in a very large and very well registry from Denmark, supported from the Kaiser Permanente in Western, California, Northern California, is that obesity in adolescents and especially in girls is a problem.
It really is.
And that's becoming more and more that it may actually increase the risk for developing MS. Yeah. Very, very important. Watching the diet, healthy diet, it's very important. And additional, what was actually a recent study coming out now from one of my colleagues that was trained with me here at Buffalo and Dr. Ye, that's now it's in sick children in Toronto. They showed that children, and that is not only for the risk, but eventually to prevent further deterioration, is actually exercising and having children involved in team
sports and activities.
They clearly showed benefit on preventing relapses and preventing new lesions. So anything that we shown as risk factor for developing the disease are also showing being risk factors for disease progression. So very, very important. Being healthy, exercising, eating healthy, and being, as I said, a good sleep too, meaning a sleep hygiene is very, very important. Difficult on adolescents, it's true.
Right. But that scheduled sleep and keeping them on a schedule, I mean, I think that's important all the way around.
Absolutely.
Yes.
Absolutely. All what we're calling the circadian cycle is actually very much linked to the immune system. And it's very, very important, meaning, we see circadian cycle problems in shift worker.
Yes.
With increasing in obesity, increasing more so, I know that we have nurses and people that have to work during nights and so on, but that is really a very high risk for different diseases, including obesity, and obesity is related to all this, chronic diseases, including autoimmune problems.
And as you mentioned that, I was in the medical field, and in our largest forums on social media, we notice a large percentage of healthcare workers and people who work those stressful jobs and those long jobs. We notice a large percentage of patients in those groups.
That is very interesting. It was a paper looking on the effect of, moving and getting, clearly moving and standing up at work is important.
Yes.
And after that, they did a sub-analysis of all this moving and so on. And actually, when they looked on, especially whoever was more concerning were the health, providers. But what they found is actually probably the stress.
Yeah, the stress.
Actually was more important sometimes than sitting down versus moving. So it's very important to try to exercise, yoga, any kind of mindfulness intervention.
Yes,
very,
which is what I do, yes. I do, but I believe that the yoga, the mindfulness, the water therapy, all of it is not only can be preventative for our children, but also can help control symptoms for those of us who are adults who have multiple sclerosis. Now, that leads into another question that many people have about diet. Because they're told, okay, watch your diet, your nutrition, it will help control your symptoms. But there's so many diets out there in social media that they get bombarded with, they get confused. And first of all, I recommend, as you probably do, to see a nutritionist that their doctor will recommend. But they get bombarded because sometimes you have to tweak them and see what works for you. Not everything works for every person. But what diet, per se, do you recommend for those living with multiple sclerosis?
So there, as you said very well, there are a lot of diets out there.
Yes.
In my first study ever was actually 20 years ago, and I went to the strong diet, a low-fat, saturated
Yes.
diet, and but clearly the diet alone will not be sufficient.
Right.
You have to be this as an add-on to the medication. Now there is an ongoing, and probably many of your auditor they are knowing about wall diets. And more protein is the so-called new paleo diet.
Yes, the paleo.
So it's again, there is an ongoing study that MS Society actually put together to compare the two of them. So we'll see what the results are showing and so on. I do really believe the healthy and really well-equilibrated diet is very important. Saturated fats are not good.
Right.
And I'll tell you where it's coming. We have a lot of data for the last 8 years on the high cholesterol.
Yes.
High cholesterol really is affecting MS, not only cardiovascular and so on complication. We had data showing on the high cholesterol, even in patients with the first event, what we're calling clinical liver syndrome. We have a study on all the patients were treated, and really the patient with high cholesterol, young people, first event, actually with high cholesterol had more lesion in the brain than the ones without it.
You know, interestingly, I don't have high cholesterol yet. My doctor put me on a statin to see if that.
Actually, this is bringing me back to that I forgot to say for the first question about there's an ongoing study for patients with progressive disease with simvastatin in the UK.
Yeah.
And this is also primarily with outcome, again, MRI related to prevent brain atrophy. So, the statins do have more, we're calling this pleiotropic effect. It may have much more effect in decreasing the cholesterol, and they have this anti-inflammatory. But in the end, really the cholesterol is, a bad guy. And what is showing more and more, the way how, looking for the good cholesterol versus the bad cholesterol, the bad cholesterol is bad.
Yes.
And, the protection from the good cholesterol is not so clear. There are really different, data coming out of it, but high LDL, the bad cholesterol, or if it's possible to measure, as they're trying now to do the so-called ApoB, that is kind of more sensitive than the LDL, it's clearly very important to control it. Control it with diet, control it with exercise, if it's not possible with statins. High-dose statins, though, again, it's may have certain side effects, although, again, it's a low number.
They really do.
The benefit is overcoming the side effects.
Yeah, that's the challenge right now. Now, thank you so much for joining us today, Dr. Weinstock-Guttmen. It really was a pleasure. And you're welcome back anytime to share information with our listeners.
Okay.
And for you take care. Thank you so much. For more information, visit our website, www.msandmemedia.com, and join us again next week on MS&Me Interviews.